Thank you for the presentation of this quite interesting study, focusing again on the question whether or not Asperger's and high-functioning autism is more or less the same, yes or no. I'm very curious to hear the opinion of Patricia Houding in answer on your presentation. The last presentation is by Inge Kamp-Becker from University of Marburg, Germany, and the title of the presentation is Result from a Diagnostic Examination of Participants with Asperger Syndrome and High-Functioning Autism. So this all completes the picture, I guess.
Thank you. So it's late, and I think I have to wake up you from time to time. But let us first see what do my data says. So currently we are speaking about the spectrum of autism disorders. The high variation of the pathology of autism disorders is summarized by this term. The autism spectrum disorders therefore include a multiplicity of symptoms, a wide range of clinical manifestations, and a great range of different levels of functioning and development. In ICD and DSM, the pervasive developmental disorder subtypes are sharing symptoms from three symptoms domains from three dimensions, which are social interaction, communication, and repetitive stereotype behavior. But this conceptualization into these three domains or dimensions is mainly made on clinical judgment rather than on empirical data. So there is a controversial issue about the question which Professor van Engeland has mentioned, the question whether the high variability and complexity of clinical presentation represents different qualitative categories of autism which may be accounted for by different genetic mechanisms. So this means that Asperger syndrome and autism are different autistic phenotypes. And another position is that they are caused by a variation of a single or of a multiplicity of dimensions which have to be named clearly. According to this question, I want to present some results from examinations with high-functioning individuals. Our sample consists of 141 subjects, 6 female subjects. The age ranged from 6 up to 25, and the IQ from 70 up to 139. So it is really a sample of high-functioning affected children. The 104 subjects read an autistic diagnosis, and 37 subjects got a diagnosis of non-autism, which you can see here. But it's very important to stress the fact that all subjects came in our clinic with a suspicion of autism and were examined for this. This means that even the non-autistic group has a real autistic near or autistic similar symptomatology and behavior. This is reflected in the fact that all these non-autistic diagnoses are differential diagnoses of autism. There were no statistical difference between the groups in respect of age and full IQ. So what did we do? All participants were assessed with the Autism Diagnostic Observation Schedule and the Autism Diagnostic Interview. The mean kappa value for the inter-rater reliability for this instrument was about 0.75. And the diagnoses were made according to the ICD-10 criteria. The adaptive behavior was collected by the Vineland scales, which have 3 domains: communication, daily living skills, and socialization. And we made neuropsychological testing, the IQ with the Wechsler scales, and a series of mind testing, which included face recognition of perception of emotion, which you can see here. Here the task is to, what I say to the child is, on what picture does the woman feel like this man? and you can then you can have the amount of right answers, and also you have the time they need for the answers. Thirdly, we made the social attribution task, well known from other studies. This is a short film you can see here. And the task here is to make a description what is happening. And the question is the description, does it include social attributions, or does it only is a pure factual description of what happens here in this film, what you can see here. So the question in this situation is it the child saying they bump together, or is it saying they are fighting? Okay, we made also a task, the perspective task, which is this hippo. And here the question is whether the child can take the perspective of the hippo and tell the situation out of the perspective of the hippo. So you see, that's the perspective task. All this theory of mind tasks were summarized by factor analysis into one factor, which was included in the further analysis. We also made further examinations in respect to executive functionings, spatial perception, central coherence, attention, motor behavior, and so on. So, first, the categorical approach. The categorical approach means that the autistic orders can be divided into independent categories. This means that they have an intersection indeed, as we can see here, but nevertheless they can be classified in different categories. Non-autistic disorders can be confined clearly of their qualitative otherness. In this approach we can make a clear discrimination of normal and autism, and also between Asperger syndrome and autism. In response to the question whether Asperger syndrome could be differed in a categorical manner from other autistic disorders, we have chosen a multivariate statistical analysis. We choose this approach to avoid circularity in the argumentation, so we have made no assumption to the diagnosis but formed one sample. In other words, we lumped all together, all subjects in one bottle, shaked them, and then we looked, is there a cluster which can be named Asperger syndrome or autism or non-autism. So we tried this too, but we can't find a cluster, different clusters. The majority of subjects were assigned to one cluster. More than 85% build one cluster. So the conclusion is that we cannot distinguish Asperger syndrome and autism into different categorical groups. So if we can't do this, we come to the dimensional approach. In a dimensional approach, we talk about a spectrum of autism. I want to illustrate this by the spectrum of colors. The dimension varies here from a bit autistic to up to extreme autistic. The evident problem of the dimensional approach is the differentiation between normal and disorder or other disorders or normality. The dimensional approach means that the dimension varies from what we call a disorder and what we call normality. So there is no qualitative difference, only a quantitative. The neural results of the broader autism phenotypes, meaning that a single symptoms of autism were also found at relatives of autistic child, indicate this. Therefore, we have to make a cut-off point for the difference between autism and other disorders and normality. The problem is, where is this cut-off point and how can we define it? If we think this dimensional approach out, it means something like every male is a bit autistic, because mostly males have a lower emphasizing, or in the mean they have a lower emphasizing quotient than females. This is a point of view which Baron Cohen focused in his book. Or also, as Hans Asperger said, in the autistic individual, the male pattern is exaggerated to the extreme. But I don't think so. I think many of the discussions about the confusions about Asperger syndrome is a confusion about this cut-off point. And so for this, we have to take standard instruments like ADOS and ADI to make clear where is a cut-off and how we define it. But another question is, what determines this underlying dimension? Is it just the intensity of the pathology, or is it the intelligence which varies from low to high, or is it just the adaptive functioning which could be high or which could be low? So to these questions our study was made, because it is made around this cut-off point, because we have a sample of high-functioning subjects and samples with a really autistic near symptomatology. Okay. There are some studies which research also these questions and which research the dimensional structure of autism spectrum disorders. All these studies are also made from data from the ADI, and they vary very much in respect to what they found. As you can see here, in this study only one dimension was found, and in this study it's 6 dimensions. But there are also highly differences in the sample size and in the age range, in the IQ range. Some studies included only autistic child, some include children with PDD-NOS, and some studies include children with non-autism diagnosis, and so on. And the item pool which was selected is also very different. You can see some studies only take the algorithm data from the ADI, and some studies take all items from the ADI. Here are the studies that were made for the restricted repetitive behavior domain, and you can see that the results seem to be a little bit more homogeneous. So in our study, the key question was, what is the underlying dimensional structure of high-functioning autism spectrum children, and by what is it affected? A second objective was to examine the association between these derived factors and other variables such as current pathology, age, intelligence, theory of mind abilities, and adaptive functions. So the question is, what explains the variation in these underlying dimensions? And another question, what is a predictive factor for the current pathology of autism symptoms in a high-functioning sample? So here are the data for the ADI. The ADI asked for the autism-specific pathology concerning the early development from a retrospective point of view. Because the algorithm seems to be too short for this sample, we took all ADI items, but we excluded items which were coded by over 90% of the sample with a 0. So we got a 5-factor solution. The following this 5-factor solution explains 40% of the variance, and the first factor is named social communication and declares 17% of the variance. And also, as also seen in many other studies, this factor implies items from the social interaction and communication domain, so that the division into these domains, into two separate domains, we couldn't find. The factor is very similar to the factor of other studies like impaired social communication skills or social communication in a study from this year. This factor correlates on a 5% level with the performance IQ. The second factor contains items like mannerism, echolalia, sensory interest, and so on. It is named stereotype behavior and speech. And there is a correlation to the performance IQ, which is significant. There are also very similar factors found in other studies, and the third factor is called anxious and compulsive behavior, and it includes items like resistance to change, compulsion, sensitivity to noise, abnormal reactions to sensory stimuli, rituals, and so on. And this factor explains 7% of the variance, and there is no significant correlation to intelligence. The fourth factor is motor behavior and special interests, and there is a significant correlation with the verbal IQ, and the last factor is called abnormal reactions. So on this slide you can see how the diagnostic group load on the different factors. On this axis you see the diagnostic groups, and here you can see the factor loadings. It's evident that the non-autistic group shows a very different pattern of factor loadings. The autism groups differ from the non-autism group concerning the first three factors, but not concerning the factor 4 and 5. The diagnostics group show a pattern which is very similar to that what is described in ICD. The Asperger syndrome group and the high functioning group differ in respect to factor 1, 2, and 4. So here are the results for the ADOS. The ADOS is a half-structured interview which captures the autism-specific pathology in the current point of view. For statistical analysis, we put together module 3 and 4, and again we refused items which was coded for 0 by over 90%. So we get 22 items for the factor analysis and reached also a 5-factor solution. The first factor is again called social interaction and communication, and it again combines items from the social interaction and the communication domain. Interestingly, there is no correlation between this factor and intelligence, in contrast to the results from the ADI. But there is a strong correlation to the Vineland socialization domain scores. The higher this factor of the ADOS is, the lower is the socialization score. The next factor is mainly influenced by hyperactivity. There is no correlation to IQ or adaptive behavior. The third factor shows a significant correlation to the performance IQ. The higher this factor is, the lower is the performance IQ. While the fourth and the fifth factor show a correlation to the verbal IQ. And here again you can see how the diagnostic groups load on these factors, and again you can see that the non-autistic group shows a very different pattern. As our data implies a great range of age, you remember it was from 6 up to 24, we also made analysis to see what makes the age, and these results you can see here. On the left side there is a group with an age under 11 years, and on the right side the age is 11 years or older. And on the left side is the autistic groups, and on the right side the non-autistic groups. It is evident that the factor hyperactivity bears upon the age of the subjects. For both diagnostic groups, this factor decreases the older the subjects grow. In relation to this factor, the group doesn't differ, but the difference in relation to age is highly significant. It is the only factor that shows a significant decrease within the diagnostic groups. The other factors are stable in relation to the age. Here you can see the results for the Vineland and IQ. Yeah. So I will spring and come to this point. We made a linear regression analysis in respect to the question, what are predictor variables for the actual presentation? So we use the ADOS factors and the Vineland scores as criteria variables, and for predictive variables, the ADI factors, the verbal IQ, performance IQ, theory of mind skills, and the age. And what I want to show you in this table is that, again, the non-autism group, which is shown here, could not be good predictors from these factors. For the autistic group, the anxiety and compulsive behavior was the best predictor for the social and communication skills in the current presentation. And also the abilities in this domain in the early development was a good predictive factor, and also theory of mind and the age. Intelligence was no predictive factor for the abilities in the social and communication domain. For hyperactivity, the best predictor was the age, and also the stereotype behavior in the early development. And for speech abnormalities, the motor and special interest factor of the ADI was the best predictor. So intelligence was not a good predictive factor for anything in this analysis. For the adaptive behaviors, we could see that the verbal EQ is a good predictor for communication and daily living skills, but for the socialization domain, it is not. For the socialization domain, the early social communication abilities is a predictive factor, and also in a negative relation, the age and the theory of mind abilities. So I come to the summary. And what I like to say for practical applications, this means for the therapists that you have to treat anxiety and compulsive behavior very early and very intensive. And to the parents, I would like to say, with the growing age of the child, hyperactivity, sensory interest, mannerism, and so on will get better. But you have to train the social skills very much to minimize the gap to other children. Thank you for your attention.
I will?
Yeah.
Okay.